This is Mitchel Zoler from Global Medical News Network. I'm reporting from Orlando at the annual scientific sessions of the American College of Cardiology. I'm speaking with Professor Germano Di Sciascio, who is a professor and director of the Department of Cardiovascular Science at the Policlinico University in Rome. And this morning, Dr. Di Sciascio at the meeting reported on treating patients with 2 loading doses of atorvastatin prior to their PCI procedure, and these were patients who were already on an established statin regimen prior to coming in for their procedure. And so, Dr. Di Sciascio, if you could briefly describe what was the effect you saw of this treatment?
Yes, we applied this treatment to patients who are already on chronic statin therapy for the reason that this patient population is increasing nowadays in our cardiology departments. What we did, we applied a protocol of 80 milligrams of atorvastatin given 12 hours prior to the procedure, followed by 40 milligrams given approximately 2 hours prior to PCI, and we evaluated the incidence of periprocedural MI and the follow-up for 30 days, the 30-day MACE of MI, death, and target vessel vascularization. What we found was that the general population of chronic statin users did benefit from this additional reload with a high dose of atorvastatin, with an incidence of MACE going down from 9.1 to 3.4%. When we looked at the population subgroups according to clinical presentations, we found that while patients with stable angina had a non-significant benefit, patients with unstable angina had a very significant benefit from this approach, with MACE going down from approximately 14% to 2.5%. So basically our conclusion was that even patients who are on chronic therapy can benefit from a further boost of statin load or bolus, so to speak, prior to a PCI procedure. And also, especially the unstable patients, who are the sickest patients, of course, are the ones who benefit most from this potent load of anti-inflammatory or maybe anti-thrombotic therapy, which is represented by statins in this setting, i.e. the pleiotropic effects.
Right. So going forward, it seems as though it's particularly the acute coronary syndrome patients who might benefit the most from this. And so this study was somewhat small, about 300 patients.
352 patients. So
where do you see as the next step in developing this approach to treatment?
Well, the next step would be to evaluate what is the clinical significance of periprocedural MI, in particular the extent of periprocedural MI measured by MRI, and also to see in the long term what type of consequences the diminution of periprocedural MI will have in terms of survival and left ventricular function.
And in some of the discussion today, you were actually suggesting that the finding and the experience generally with the protective effect of statins in the patients undergoing PCI suggests a value for patients simply on their own if they already have statins on hand, because they're prescribed them, to take one at the time when they have chest pain and so on, and they're calling their physician or an ambulance.
We have been advocating an early and upstream atorvastatin treatment in patients who present with a coronary syndrome, acute coronary syndrome, even STEMI. We believe that a statin load is part of the first-line treatment in patients who have an acute coronary syndrome. And statin probably should be given the same way that aspirin is given at the first medical contact, or a beta blocker, or other antithrombotic agents like clopidogrel, for example.
Yes. Very good. Well, thank you very much, Dr. Di Sciascio. This is Mitchel Zoler from Global Medical News Network reporting at the annual scientific session of the American College of Cardiology.